which is the think tank of the European progressives, a think tank that is engaged in Brussels, in Europe and beyond, to provide fresh thinking and ideas to set the new course of action for progressive political action. The moment is crucial for many, many issues, and I don't want to mention the crises, the wars that are affecting all of us, but it is rather clear that after the pandemics, Europe had to step up a little bit its ambition in order to protect the health of the continent and deliver better health outcomes. This is why we have engaged with several important partners. The most relevant today is the European Institute for Health and Sustainable Development, based in Lithuania, with who we have come up with the idea of a big book that can condense together the last period of health integration and the way forward for what we like to define and call the European Health Union. So it's a very happy day for us, because today we are launching in this webinar on the progressive vision for the European Health Union. We are launching a book that comes from an year-long work on the European Health Union, a blueprint for generations, which you find on FEPS website as of this moment. So now it's available to all of you. And we have the pleasure today to have authors of the book and important commentators to discuss some of the content, so you can have a hint about what we are talking about, just if you stay connected for an hour. But of course, if you're working on health, if this is your subject, the book is relevant into the details of the different angles. We are very happy to have here with us today Vytenis Andriukaitis, that besides being the editor of the book, is also the former European Commissioner for Health and Food Safety, and currently is the WHO Special Envoy for the European region. Thanks, Andriukaitis, not only for being here today, but for the entire big effort on organizing and making the book and the contributions ready. We will also have the pleasure to have FEPS President Maria Joao Rodrigues, that is, as you know, as she has been the leader behind the European Pillar of Social Rights, that also stressed the relevance of health for all European citizens. We have with us two of the authors contributing to the book. Professor Schrouwen from the University of Amsterdam, and Ilona Kikbush, founding director and chair of the Global Health Center at the Graduate Institute for International and Development Studies in Geneva. We are also extremely happy to have an input from Sara Cerdas, a member of the European Parliament, and she's also the S&D coordinator for the subcommittee on public health. She's working on different topics on health, specifically also on the report on data space. And we are also super grateful to Troels Petersen, who connects with us from Denmark. He has been a member of the Citizens Panel in the Conference on the Future of Europe, and he was working specifically on the working group addressing health. So we will have the possibility to listen from the citizens' requests on health. But in order to give officially the beginning of the book, I will soon give the floor to the editor Vytenis Andriukaitis. But first and foremost, the floor goes to President Maria Joao Rodrigues for an introduction on where we stand in terms of the big challenges to design the future of the European Union and the future of health and the social quality well-being for Europe. I give you the floor, President, while remembering and telling to all colleagues and people that are listening to us that they can already start asking questions or commenting both on the Zoom as well as on the YouTube channel, so that we can try to somehow integrate some of the comments and the questions that might arrive in these two digital tools, as well as they are all invited to check FEPS website to have a grasp on the book itself that's just been launched. President Maria João Rodrigues, you have the floor.
Thank you very much, David, and good morning to all of you. It's really a great pleasure and a great honor for us to launch today this book on European Health Union, Our Progressive Vision. Let me tell you that the idea to work for this book started when we were completely confronted with the COVID-19 during the pandemic terrible situation. And I remember that by that time, I looked for my good friend, former European Commission, Vytenis Andriukaitis, and I told him, Vytenis, tell me what we should do to come up with a real progressive response. You can really be a key actor of developing this progressive response. You have such an experience. You are such a respected personality. And Vytenis told me immediately, yes. And so we start working together. And I remember that in the middle of the pandemics, we ran online also experts meeting. And this was, I think, the starting point of a great FEPS project, because we could start building a real expert group, providing all the necessary expertise to come with such a quality book. I'm so proud of the quality of this book. I think this is quite unique in the current published reports. Our concern, first of all, was to start with a clear concept of a progressive approach for health policies. And look, the idea is very simple, is that we as progressives, we want to make the best of science, new solutions coming from science, but making these accessible to everyone. And this involves accessible universal health coverage. This is a very ambitious goal, and also because we know that the very concept of health evolves over time. And even today, we have a rich discussion about what should be the One Health principle, and how can we have a healthy life, but also a healthy interface with our planet. And this is full part of what we call the Sustainable Development Goals agenda. Then in the progressive approach, we also take into account that this is also about having in mind citizens' needs and aspirations on one hand, but also about having in mind the workers of these sectors, the health workers, the scientific workers. We also want to provide them good working conditions and to make the best of their contribution. So we know that these took decades for us Europeans to start building comprehensive, inclusive health systems. This remains an historical task. But what is at stake now is to see how should we develop the European dimension of health policy. And let me identify briefly the main issues for this. The first one has to do the way we govern our European single market, to make sure that the principle of free mobility is not turning into risk of a kind of brain drain. And we need to make sure that there is proper coordination between member states to secure the necessary labor forces in each country. And I would say that this starts by applying the European social pillar to the workers of the health sector. They need to count on decent working conditions. The second issue is the fiscal conditions. We need to make sure that in our national budgets, they do have the means to finance inclusive health policies. This involves taxation, but this also involves wise European fiscal rules. And I'm saying this because right now we have an important discussion about the reform of the Stability and Growth Pact, and we cannot repeat the mistakes of the past of imposing austerity and sacrificing basic income to protect citizens' health. And then we have the third big issue is what can we do together at European level? When it comes organizing public procurement, we saw this during the pandemics, public procurement on new kind of vaccines. When cooperating for research and development, and also when cooperate to address rare diseases. I believe that for these kind of actions, we do need to have stronger European bodies. We require action at European level. And last but not least, the global dimension, because we know that for us Europeans, it's also important to cooperate with our partners across the world to provide better health solutions for everyone. And we saw this during the pandemics, but this should remain a crucial concern for us. Well, I would like to say to conclude that this discussion brings us to a very important objective for European construction is to provide new public goods which can only be provided at European level. Some of them can be provided at national level, but others can only be provided at European level. And that's where this is one of the conclusions we have reached with our collaboration with this expert group, and particularly with Andriukaitis. That's where we are also coming to the conclusion that the current EU treaties, they have limits and they should be updated. If this is an area where we see the clear need for updating the European treaties is exactly the health sector. So we are also working for this, but for the time being, I repeat, I'm extremely proud that we could achieve such a quality book. So my big thanks and special gratitude to the authors, to the discussants coming also today, and finally for the FEPS team, which was behind all these with a big achievement. Many thanks again.
Thanks a lot, dear President, for this somehow great overview of what we need to do in the different aspects of health. Let's dig into the matter of the book and therefore of the content of it as fast as we can by giving the floor to the editor of the book, Andriukaitis. I pass you the floor to explain us what's inside the book, but also why and what are maybe the key messages that you want people to remember. But while giving you the floor, please allow me also to extend gratitude to you, to the other editor, Gediminas Cherniouxas, to somehow the editor in charge from the side of FEPS, my colleague Iuliana Omes, that has as a project management coordinator for this, has a great support in the publication, and also to all the authors that contributed. Andriukaitis, you have the floor. Please tell us why we should see this as a relevant publication for the future of the construction of health integration.
Thank you, David, for your kind words. And dear Maria, I am so happy to see you. I remember our common work when you did a lot putting forward issues about European social pillar and summit in Gothenburg, because at that time we were together. You were in European Parliament, I was in European Commission. I spent a lot of time and did a lot of issues that also health was included into such social pillar. And thank you very much for your kind words. And I would like to also thank all our team, all our researchers, all our colleagues, putting their efforts to have such, the excellent book from my point of view. Okay, let me start. In our book, certain questions have been researched. Why was the European Health Union or EIHU a new entitlement of the European Health Policy Board? How would a stronger European health policy connect with the European Union Pillar of Social Rights, the European Green Deal, and the commitment of the EU and its member states to the United Nations Sustainable Development Goals? What are avenues of pan-European health policy with the biggest potential to bring benefits for the European citizens, or so-called European added values, especially keeping in mind European public goods, and health is one of those public goods? What institutional changes are needed for the sustainable progress of the European Health Union? What are the most urgent steps on the road towards a genuine EIHU, and how important is a discussion on changing European treaties for the development of a healthier Europe? Please, first slide. And in our book, you can find three fundamental parts. Part one is called Fundamentals of European Health Union. We argue that the recent strengthening of European health policy, today commonly referred to as a EIHU, is an outcome of decades-long socio-economic developments in Europe. The COVID-19 pandemic was a trigger, but not a cause of the EIHU. Thus, pan-European health policy should concentrate on all avenues promising European value added, not just preparedness for future crises. Europe has evolved from an industrial society to an economy where service is predominant. The economic transformation was accompanied by the demographic transition and the development of institutional protection. And you see main authors, Markus Schneider, Gediminas Černiauskas, Helmut Brandter, Issam Al-Samara, and me. We presented such common views describing fundamentals of European Health Union. Today, almost 10% of value added is created by the production of health goods and services within the EU27. National European market and non-market regulations, as well as international contracts, safeguard the value chains of production. Digitalization of the single market also will create a European health data space, which, together with the advance of artificial intelligence, generate new opportunities and challenges far beyond national capacities to govern them. The internal market of goods remains at the core of today's European integration, but socio-economic transformation and shifting of national priorities in favor of health and other social sectors are contributing to the growth of the relevant importance of these sectors in pan-European politics. Of course, it was translated in the Treaty of Amsterdam, and then in 20 Principles of the European Pillar of Social Rights in 2017. According to Eurobarometer data, Europeans hold a positive perspective of the EU, trust the EU more than their national institutions, and want their voice to be heard more within the EU. Moreover, health is consistently ranked among the primary concerns of European health citizens, of European EU citizens, and Europeans call on the European integration to prioritize public health and to have a common EU health policy. It is very important now to stress about public opinion, because public opinion in front of new European Parliament elections can play a very important role. During the citizens-led conference on the future of Europe 2022, the panel recognized the necessity of revising Article 4 of the Treaty on the Functioning of the European Union to encompass health and healthcare as shared competences between the member states and the EU. And it is, like to say, citizens' voice for all of us. The evolution of the health role of the EU has been marked by a gradual recognition of the importance of health as a fundamental right and the need of coordinated action at the EU levels to address health challenges. But the responsibly established health institutions and the scattered capacities and competencies for policymaking on health systems and public health at the EU level are regarded as following the failing forward trend of European integration. And it is now time to change this trend. The EHU has many co-benefits in synergies with major policy framework, both in Europe and around the world. The EHU can contribute to European sovereignty and promote peace in the continent. The EHU would promote sustainability through its many interlinkages with the European Green Deal and Sustainable Development Goal. The EHU can enhance the digitalization of objectives of the European Union. In our second part 2, main avenues for pan-European cooperation for health, we studied fields of pro-health actions that, according to the authors, are the most promising for the health and well-being of Europeans. And we invited authors who decided to look into areas where only pan-European added value can reach better results to ordinary people. It means when we are speaking about crisis preparedness, it means when we are speaking about rare diseases, multi-complex diseases, and rare cancers, it means when we are discussing issues related to universal health coverage, or healthcare workforce shortages and medical doses, or when we are speaking about pharmaceuticals, about shortages in medicine, or about possibilities to innovate in area of new treatments and advanced therapies. And of course, Thibaut de Ruelle looked into situation today's proposed in area of preparedness and response to cross-border health threats. As you know, European Health Union now presented as being 5 building blocks. One of them is preparedness and response to cross-border healthcare threats. Second, pharmaceutical strategy. Third, Europe beating cancer plan. And fourth, long-term care strategy. And fifth, mental health strategy. And looking into preparedness or a lack therefore, it was a major issue for EU countries during the COVID-19 pandemic. The current reforms do not adequately address the problems of preparedness. 3 paradigm shifts: joint procurement, scientific agency capacity, and recognition of interdependence would offer an opportunity to integrate preparedness as a shared competence. Of course, speaking about innovations in life sciences, it is a result of the interplay between academia, public institutions, and private companies. And here, Richard Bergstrom presented his views about possibilities. How can we do more and achieve better results promoting progress in health technologies through a centralized process to approve new medicines and devices, to orphan medicine regulation, to develop and foster new vaccines by creating a European Union buying club to invest broadly in a portfolio covering the 4 identified technology platforms, and also thinking about possibilities to use such buying club tools as economy of scale, buying, for example, medicines for people suffering from rare diseases. Dominique Bolton, she analyzed situation with universal health coverage. And EIHSD is one of the targets of the 2030 Agenda for Sustainable Development goals. But improving people's access to healthcare services has been a long-standing objective in European countries. But available data already show that there is a room for progress towards universal health coverage, and that there is wide variation and inequity between and within member states, and it should be addressed only with common efforts at member states level and at EU level. Of course, Birute Tumėnė and Mauricio Scarpa, they presented here you can see coverage dimension of speaking about universal health coverage, which was presented by Dominique Bolton. And of course, here is very important proposals to see 4 components: population coverage, service coverage, cost coverage, and service access. And incapacity to formulate requests to service access is now big challenges for all of us. Speaking about rare diseases and rare cancers, you can see how is unequal EU in area of those those pathologies, and Mauricio Scarpa and Birute Tumėnė, they claim that European health income countries provide universal access to high quality health care, but it masks huge gaps in coverage and marginalization of particularly vulnerable groups in our societies, including people living with rare diseases. And much work has been done to tackle rare diseases, but even greater challenges lie ahead for Europe. Only when patients no longer have to wait for 5 or 6 years to get an accurate diagnosis, and sometimes pass away before reaching it. When a high-quality, effective, integrated, and coordinated treatments are given to at least 95% of patients, rather than a mere 5% as today, when patients and their families become happy and fully integrated members of our society, only then we will have a right to say that we did not leave the most vulnerable behind. And of course, Annette Schrauen and Corina Hidlopen, they presented views related to healthcare workforce shortages, but it would be presented by Annette today. And I see Ilona can present situation with EU global health strategy, which is a major historic step in relation to external health activities of European Union. All those areas require common efforts at European level and national level. And in part 3, we are analyzing policies of transition towards a healthier and more socially inclusive Europe. The EU paid with human lives and huge economic and social losses for the fact that, especially in the first phase of the pandemic, the development of common European health policy progressed slowly. And European statistic on treatable and preventable mortality reveals important findings. The divide in health status between Western and Eastern part of the EU is far from being closed. All countries with figures below the EU average are from Central and Eastern Europe. Health status improved across Central and Eastern European countries from 2011 to 2008, but it was not sustained during the COVID pandemic. In 2020, an increase of treatable and preventable mortality in comparison to 2011 was recorded in Bulgaria, Poland, Romania. The reduction of treatable and preventable mortality in Central and Eastern European countries to the level of EU average would save up to 150,000 lives annually. It means how can we, act together, keeping in mind added value when we will act at European level. Of course, we know very well that now we have risk that looming, overlapping energy, food, financial crisis associated with a protracted war in Ukraine and today Middle East crisis and war in Israel against Hamas are relating health issues to relegating health issues to the background. It is very difficult time, and we need to do more to keep health policies high on the political agenda. EU operates on the basis of what constitutional lawyers call conferred and enumerated powers from member states to European institutions. EU has a powers that is founding treaties allocate to it, and not more. If the legislative powers based on internal market are capacious, of course, the public health ground is much more weaker. In the EU, here is strong legal ground speaking about creation of the union. Custom union, economic and monetary union, strong internal market with energy, digital, banking unions, because they all are enshrined in the treaty, and there you see exclusive and shared competences of the EU. But when it comes to the issue of social policies or public health and healthcare issues, here the EU is limited, and its limited capacities only to support, coordinate, and supplement member states' activities. It means that that new coin title, the EHU, has not the same weight as, for example, banking union or digital union and customs union. Please, slides. And of course, speaking about EU budget and how many financial resources we are dedicating to those policies where EU has shared competences, and it is good slide to show how which is proportion compare money dedicated to EU for health program and other European financial means. Even after this substantial increase, which was achieved from 2021 to 2027 till 5.3 billion, the budget of European EU for health program is not exceed 1% of total annual public health expenditure of the EU member states. It means that we need to move forward, speaking about European Union own resources and possibilities to provide more financial efforts in area of health. Next slide. And of course, we are proposing, keeping in mind legal frame, keeping in mind limits which are enshrined in Lisbon Treaty, we are proposing scenarios A, B, and C. Scenario A requires to use measures to make progress in health, concentrate on what can be done with existing legal, financial, and managerial instruments, upgrading already functioning institutions, and improving implementation of already agreed policies. Scenario B, which is promising issue, speaking about the future steps, is development of secondary legislation, establishment of new institutions that are supposed to create European added value in parallel to the fine-tuning of existing instruments for health policy. This scenario does not foresee amendments to the European treaties, but the status of health policy in the European treaty is strengthened with provisions for a European Health Union incorporated in the Treaty on European Union, giving the European Union some shared competences in health policy in very concrete areas while preserving the principle of subsidiarity as a core. The EU needs to speak explicitly about health as an aim of the EU and its commitment to build an European health use as a tool to assure good health and longevity of Europeans. The Health and Wellbeing Union should appear in the paragraph 10 of the preamble of the Treaty on the EU, paramount to the internal market and an economic and monetary union by inserting the words health and social. And part 3 of Article 3 of the Treaty on European Union should be amended with one last sentence. It should promote universal health coverage by establishing a health union. And then where we will see equality between those unions like customs union, banking union, the monetary and economic union, and health and well-being union. And of course, also I am not going into details because all those scenarios are described in very detailed manner in our book, in our part 3. But let me say only few last sentences. Main avenues for pan-European cooperation for health include, but are not restricted by preparedness and resilience. They are strengthening of solidarity within and between member states, based on the principle of progressive universalism, providing support, including universal health coverage, but respecting principle of subsidiarity as a core, solidification of emergency preparedness and response, expansion of EU cooperation in research and development, enhancing cooperation on the management and treatment of rare diseases, rare cancers, multi-factor diseases, guaranteeing equal access to innovative medicines without financial hardship, working together to address an equal distribution of healthcare workforce capacities in Europe, and developing a global health policy, working with the United Nations in its specialized agencies, especially in strengthening World Health Organizations. The demand of Europeans regarding public health issues have been clear and unequivocal. Now, its responsibility lies in the hands of elected politicians to respond to aspirations of citizens and to take the necessary steps toward building a more comprehensive and more cohesive European Health Union policy. And our book has such goal to show to politicians, to citizens, to national parliaments, how can we, based on research and based on evidence base, develop new stage of development to European Health Union. Thank you very much indeed.
Great, Mr. Andriukaitis. Thanks a lot for this, how can I say, short and intense excursus on the lot of content that you have been able to produce in the book. I'm very glad that we have recorded this 15 minutes, so you know that we can go back every time and have a powerful summary of a lot of the content that is included in the book. But stay tuned, because we will have very soon a dig into two of the core topics of two of the chapters that you have mentioned, one by Annette Schrauen on equal access to health workers, and the other one by Ilona Kickbush on the external dimension of the European Health Union. So we will go in depth into these two angles. But before going there and giving the floor to the authors, let us hear a statement from Sara Cerdas, a member of the European Parliament, and as you know, S&D coordinator for the subcommittee on public health, which is useful for us also to have an understanding of where politics is moving. So we are trying to push in terms of content and ideas, but as you mentioned, you and Maria Joao Rodriguez, there is an ongoing discussion on legislative proposals. We would like to understand from the S&D as well, what are the do's and don'ts and the expectations in this area. So floor to Sara Cerdas.
Hello everyone, thank you very much for the invitation and the opportunity to give some words on this very important initiative which is the launch of this book on the European Health Union. First and foremost, apologies for my voice. I'm a bit under the weather, but I couldn't let pass this opportunity to share with you some of the thoughts we have been working on and how proud we are that this book is being launched and actually reinforcing the will and the work that we have been developing here. So starting from the beginning, the European Health.
We are having indeed a technical.
From the right wing of this house, EPP, are focused on.
We can, in case come back to Sarah.
The conditions that determine the health status of the individual, conditions in which we are born, in which we live, in which we get education or not, in which we work, and so on. So, in the EIHSD group, we have been exploring the multidisciplinarity that is the science of public health, and we have been exploring Article 168 of the Treaty of Functioning of Lithuania, which states that even though provision of healthcare is provided to each individual or each community, that's member states' competency. Protection of public health is a shared competence between member states and the EU, and that's where we work on. So it is for us it's very important that we tackle all stages of disease, but one part of it that we can have most results on primordial prevention, meaning
Let me take over then, because we had the technical issues with the connection with Sarah, with the audio and the video that are not synced. If we are able, we will get Sarah's statement back in due time later on. But we have still a lot of material to go through, so let's go in this direction. As I see that Professor Schrauen is ready to kick off her presentation. Let's go in depth on her chapter that she wrote for the book together with Corinne Hinlopen. The chapter is on, as I mentioned, on equal access to health worker and managing the health worker migration in the context of the European free movement. Professor Schrauen, you have the floor to tell us the good things that you have included in your chapter. Also, I should have a PowerPoint presentation that should be up in a second.
I'm sorry, I have some difficulty sharing. Sorry.
Yeah, and maybe my colleagues can help. I think you should have the right to share your screen, as we have done already. They appear very fine, and thanks a lot.
Okay, thank you. Thank you very much. First of all, thank you for the invitation to speak at this book launch. And also thank you to the European Institute for Health and Sustainable Development that I could be part of this wonderful project. And finally, there's another thank you, and that is to Corinne Hinlopen from WEMOS, who was my co-author and with whom it was a pleasure to work on the chapter we wrote for the book. Now, the book that is launched today is a very rich source of policies and activities of why and how the EU should contribute to equal access to healthcare for all. And in doing so, the EU can contribute to the health and well-being of all European citizens. However, most of these policies and activities need the presence of an adequate workforce everywhere. Because think about it, what would universal health coverage mean if one would have to travel more than 100 kilometers to see a doctor? Would prevention measures be as adequately implemented without general practitioners to explain these to people? Now, in some countries, some regions in the European Union, there are not sufficient healthcare workers, as you might have guessed from the title of this presentation. Now, let me show you a few numbers, a few figures here. What you can see here is an overview of the density of doctors, nurses, and midwives for the 27 EU countries. And this is extracted from a 2022 overview of the World Health Organization. Now, if you look at the statistics or at the graphs, and I hope you can see them properly, it is possible to link these to free movement of persons within the European Union. And if we do so, we see that the most popular destination countries have the highest densities of doctors, nurses, and midwives. For instance, Germany, Austria, Sweden. Countries with the lowest densities include major health workers source countries such as Bulgaria, Croatia, Poland, Latvia. So these correlations are not causal per se, but there certainly is an impact of free movement of mobility within the EU to the availability of doctors, nurses, midwives in a certain country and in a certain region. For instance, there are statistics on Romanian doctors working in the more high-income countries in the EU that show that if these doctors would return to Romania, they would add almost 20% to the workforce, to all doctors in Romania. Now, please also note that the exact impact of health worker outflow remains difficult to establish because there are data from official sources, but they comprise mainly health workers with higher qualifications who follow procedures for recognition of these qualifications. It is far more difficult to track healthcare workers with lower qualifications. For instance, we know that many qualified nurses from Central and Eastern European states work in underqualified jobs in Germany and in the Netherlands, for instance, in 24/7 home care. So besides a brain drain that free movement can cause, it also leads to what is called the brain waste. Now, if we see the numbers of the disbalance, or if we see this disbalance in availability of health workforce, it is quite surprising that there seems to be a blind spot for that. First of all, if we look at language journals, English language journals on EU law, they follow topics as discussed in case law. And the disbalance of free movement of health workers is not in that case law, hardly in that case law. So very often there are chapters in books on EU health law, and these chapters, they signal there might be a problem, but that's it. And I think, if you look at EU law journals at least, this gap has to do with the fact that lawyers tend to think there is a problem with the law if there is case law on it. And if there's no case law, there's no problem. If we look at the topics here, you can see that indeed it is about those topics that were addressed in cases before the Court of Justice. There are some articles in the literature that do address the disbalance in healthcare workers across the EU, but these are mostly journals from the sending states or in articles written by authors who work in or originate from sending states. Also, I think the EU itself hardly addresses, or maybe just starts to address, the disparities in health workforce between member states and between regions. There now is a reference finally to this disbalance in the 2022 European Care Strategy, where the Commission acknowledges that there is a problem with available healthcare workers in rural and remote areas. And finally, and this has to do with the second point that I mentioned here, the perspective of sending countries in the debate on migration of healthcare workers and the migration industry more broadly is missing. I think it's unlikely that receiving states are totally unaware of the problem, but they might keep it under the radar because movement of healthcare workers from other member states is seen as a quick fix for shortages in their own system. Therefore, this blind spot is there, and it should be taken care of, it should be remedied, so to say. Now, For the EU, if we talk about free movement, it is counterintuitive to restrict it. Free movement is a ground rule of the treaty, and the whole idea behind free movement is that of efficient allocation of production factors leading to economies of scale and more benefits for consumers. So the focus always is on liberalizing and free movement, doing away with barriers. Now, that of course limits the possibilities for member states to address this balance by hindering free movement. Furthermore, also, free movement is seen as an individual right that cannot be negated and in principle cannot be hindered. That said, public health protection can be a justification for hindrances to free movement, but under very strict conditions. Now, what does this mean? For sending member states, there are limited possibilities to stop brain drain and also to stop wasting training costs, because very often it costs quite a lot of money to train doctors. And if then the trained doctors are going away to other member states, it seems like this is a waste of training costs for the sending states. There is one court case that offers a very small opening here, and that is the ITC case on a private recruitment agency working for a German job center. The facts of the case do not matter that much, but what is important is here that the court is very, very cautiously opening a possibility that in some circumstances and subject to certain conditions being complied with, there can be a prevention of brain drain as justification for restriction to free movement. But as I said, the court is very strict here. A strict proportionality test would apply. So risk of brain drain must be proven by an objective and a detailed analysis supported by figures with solid and consistent data. And that is not an easy job. Now, for the receiving member states, so the higher income member states, if they would like to restrict the number of incoming healthcare workers, they also have limited possibilities. Diploma recognition is imposed, so they must recognize diplomas, but still migrant healthcare workers are often working below their level of training, and that can be due to all sorts of additional quality standards, which again results in brain waste. And again, here also the court has kept the possibility open in the Brazil case, the possibility that in theory measures can be taken to prevent the shortage of healthcare professionals, but again under a very strict proportionality test. Risk must be proven by objective and detailed analysis, supported by figures with solid and consistent data. And an example of the high burden of proof in this high proportionality test can be seen in the Faderspiel case, which I also mentioned here. Now, what can be done to address the uneven circumstances within the EU at EU level? Well, first of all, treaty change on EU health competence has been proposed by the Conference on the Future of Europe. It is also part of the General Citizens Report. The Commission President von der Leyen also suggested it to broaden the competence of the EU. So it includes this balance in the establishment of a European Health Union, if you want. But it is questionable whether that would be sufficient. So make it a shared competence as such would be okay, but there are other barriers also in the internal market competence that say that decisions on free movement of persons are not part of the ordinary legislative procedure, but must be taken by unanimous voting. And that can be, of course, a problem with 27 member states. As I said, the General Citizens Report proposes treaty change, but I also saw the Citizens Report of the Netherlands, and that explicitly states that healthcare should remain a national competence. And of course, here a lot depends on the political will of the member states. And for now, that seems to be lacking to have treaty change in this respect. Another treaty modification proposed in the literature with respect to health and safety at work concerns giving more leeway to member states to introduce or maintain stricter measures. So you could consider a procedure whereby member states get the possibility to maintain measures, to introduce measures to prevent brain drain in the healthcare sector, but then in consultation with the European Commission, for instance. But again, treaty change for now seems not very likely. So what can be done? There is a lot to be done also with the aid of existing competences. And one of the first things that should be addressed, and this is what Corinne and I also propose in the chapter, is that there should be more emphasis on the quality of standards and the quality of data. It would be possible, for instance, to adopt a directive for minimum quality standards and report common criteria to the Commission, but there also include health workforce capacity as one of these criteria. It would be good to enforce data gathering and information, not make it voluntary, but make it compulsory. And if healthcare workforce capacity is introduced in quality standards, it makes already visible the problem. Now, data gathering is addressed in EU for Health regulation, but it limits data to cross-border threats and emergency healthcare capacity. Now, why not expand this to more structural healthcare data standards? This regulation indeed also includes a voluntary stress test, and it would be wise to make that more binding and monitor it at EU level. And again, as I said, it would make the problem visible and would make it more unlikely to ignore it or just not address it at all. Another thing that could be done by the EU is address uneven circumstances via funding. So we have the Cohesion Fund, we have the European Regional and Development Fund that could contribute to better infrastructure, quality service and education, and hence address several of the factors that make people decide to leave their state and find employment in higher income states. There is the EU for Health regulation funding. It's available for training of healthcare staff, but again, limited to crisis prevention. Then there is the Recovery and Resilience Fund regulation. There is a recital that highlights the importance of accessibility and capacity of healthcare systems. But there is also an analysis of the national recovery and resilience plans performed by DG Santé, and that gives examples from 15 member states that have proposed reforms and investments relating to strengthening their healthcare systems, but limited attention to retention of healthcare workers. And then, of course, as we already heard the president of the FEPS say, there is the European social pillar and measures under social policy. So the directive on adequate minimum wages is an example whereby structural or inequalities can be addressed. And also under the European semester, country-specific recommendations can be given by the Commission to the member states. Again, data on reporting, but also an indicator that sheds light, for instance, on the reliance on foreign trade health work force. So that would allow the Commission to address the need to invest in domestically educated health workforce in country-specific recommendations, and then might divert from the quick fix solution of recruitment from abroad in the wealthier member states. Finally, Some words on ethical codes and recruitment quickly, because I think my time is nearly up here. So there is the World Health Organization Global Code of Practice on International Recruitment on Health Personnel. And that code that maintains that migration of health workforce can contribute to development, strengthening of healthcare systems, but it should be properly managed. There's another article that says discourage active recruitment of health personnel from, and in this case, development countries, who face critical shortage of health workers. It should be discouraged. And of course, developing countries, it's not really the EU, but I wonder why this idea cannot be translated to EU context. Now, in the EU, recruitment agencies in principle fall under free movement of services. This means that, for instance, the Netherlands regulate the activities of recruitment agencies working abroad but established in the Netherlands. Now, sending countries under the services free movement have less possibility to regulate activities of recruitment agencies from the high-income countries. Now, this situation is furthermore complicated by the fact that, for instance, healthcare personnel from Romania is placed in, for instance, the Netherlands under a posted worker construction that gives even less protective rules to the Romanian workers. This is different from when Romanian workers are placed in the Netherlands and directly hired by hospitals, for instance, in the Netherlands. Now, in the chapter, we refer to research done on Latvian workers being placed in Norway under posted workers constructions. And once Norway improved its labor market regulation also for foreign workers and posted workers signing contracts in Latvia, that allowed paying less to those Latvian workers was no longer necessary. Latvian local branches of the agencies recruit and prepare migrant workers, and the contracts are signed in Norway. So Latvian workers work under the Norwegian contract. However, there's a whole industry of recruitment agencies, and this has become a business model. So recruitment agencies will develop survival strategies, expand abroad, and actively look for market potential. And I think here the EU is capable to step in under free movement of services and stop this active, aggressive recruitment from sending countries where there is already a lack, and from regions where there is already a lack of healthcare workers. Now, in conclusion, the chapter discusses several pathways, more than I now have mentioned, several pathways to try to remedy the disbalance in healthcare workers. In general, what I mentioned here is, of course, the treaty change, if that is possible, but if not, make creative use of existing competencies. Look at minimum quality standards, make sure data collection monitoring are accurate and available, put it on the European agenda, and exact data is also a way to get the problem higher on the European agenda. Broader financial support to take away the incentives for healthcare personnel to leave countries, and prevent what is called aggressive or predatory recruitment. Now, none of these, of course, other pathways are a golden solution, but I think multiple actions measures should coexist at member state level, but also at the EU level. And this also means that the Directorate Generals of the Commission, several Directorate Generals of the Commission, need to work together on this problem. But first and foremost, of course, we need a political will to acknowledge that there is a problem that concerns all EU member states and that something needs to be done about it. Thank you very much for the attention.
Definitely something needs to be done about it, and I met Professor Schrauen. Thanks a lot for the great contributions that you put up, also in highlighting where the real problem is and what are the policy directions and policy vehicles, some of which are already there and should be better used for better outcomes in Europe. We will probably go through some questions on this part later on, but let me give the floor immediately to Professor Kikush. Dear Ilona, we're very happy that you are also here with us today, and also happy to hear about the content that you shared in the chapter on the external dimension of the European Health Union, the new EU Global Health Strategy. Please. Now we've been looking at the very internal and mobility issue. Now we look at the external. Ilona, you have the floor.
Thank you very much, David. And we're already 10 minutes over time without me even having spoken. So I'll be very, very brief. And I hope I can just encourage everyone that's joined us here to read the chapter, to understand the interlink between the global and the European aspects, and to also try harder to link the global dimension and challenges of the EU with the internal strategies. Obviously, there is no European health without global health. And if one looks at the focus of the global health strategy, to deliver better health for all, that is the challenge of equity for health worldwide, and to improve global health security. You will know the words from the Director General of the WHO, nobody is safe until everyone is safe. That is clearly a direction to contribute to the production of global public goods. And you know, of course, also that one of the most important global public goods is peace. And in the present geopolitical situation, the role of health within the political arena is one that is becoming more difficult, more divisive, and calls for better cooperation between the global north and the global south. I just come from the World Health Summit in Berlin, and this direction, this issue has been very clear for all of us. We've long said that health is political and that it is a political choice, and this was also referred to by many previous speakers, but the extent to which health has also become geopolitical is something new. And the introduction to the strategy, also at the launch of the strategy, it's been very clear that the European Union realizes the increasing geopolitical importance of health, and that, as we experienced during the COVID pandemic, health has actually become something that divides us rather than something that brings us together. So the Global Health Strategy shows many entry points on how one can actually move forward. And that's not only in working together on a whole range of specific issues, it's also how we work together. And I think one of the really critical and excellent points of the Global Health Strategy is that it is moving away from the charity model, that it is clearly saying global health is partnership, is something that we do together at the same level, where we listen, where we cooperate, and where we take common agendas forward together. So I think also the Global Health Strategy will, in a number of occasions, lead to tensions with a European health strategy, because as we've seen during COVID-19, there is not only a direction of in crises to respond with a national reflex, that also in crises we respond with a European reflex. And that is why, again, I think it's so important to realize that the European Global Health Strategy has identified 3 areas that are truly global, without which also European health will not be able to be achieved. The strategy calls them enablers, and that is the digital transformation. That's a global issue per se. Even if we work on a European digital health space, that alone is not sufficient. It's the workforce issue. And of course, as the previous speaker already indicated, this is not just about workforce movements within the European Union. It is workforce movements globally that are increasingly endangering also the healthcare provision in the developing world. And more, it is the issue of research and innovation. We are seeing that countries geopolitically are competing on technological innovation, on research, on not making available data that are relevant to take health forward in all parts of the world. And many of you might know that we are right in the middle of negotiating a pandemic treaty, and issues around data transparency, around accountability, around access to technology, around intellectual property are absolutely critical. And it will be very, very essential, the positions that the European Union takes in relation to that, so that issues like, for example, ensuring supply chains is not us against them, but is actually strengthening, for example, local production throughout the world. So the 3 priority goals that the strategy has set, the first one is particularly important because it speaks about delivering better health and well-being throughout the life course. And right at the beginning of the strategy, the issue of the determinants of health is raised. And that, of course, means that many other areas of the Commission are actually contributing to the global health strategy. I've already mentioned trade. Some colleagues spoke about the Green Deal. The link between health and environment is becoming more and more critical. And of course, if we talk about equity, the whole area of the social union is absolutely essential. And we will also see that the issue of migration is going to impinge more and more also on global strategies, and that we understand that on the one hand, we cannot do a migration strategy without actually clearly understanding the need for additional healthcare personnel in the European Union. There are a lot of issues that are being taken up further in this strategy. I have no more time to go into detail. You will know the many areas that have been strengthened in the European Union around health security, all of which are working very closely with other such similar agencies. I'm just thinking of the European CDC, I'm thinking of HERA, are working globally in networks to actually make the world safer. The European Union is working and actually suggested the robust pandemic treaty. And in general, we can see that Europe is at the forefront of trying to push a One Health approach already that has been mentioned. It's difficult, though, in the global arena to have a single European voice on global health. And we have also seen that in relation to what we call the European values. We are seeing in general in the global health arena a rollback, for example, on sexual and reproductive health and rights. And many of you know that there is also a very strong divide within the European Union on these issues, which is one of the reasons we have not had council conclusions from the member states in relation to this excellent strategy. The last point I'll make at this point is that the strategy very clearly speaks about what it calls a new global health order, which is based on robust global governance. And here the European Union has been at the forefront of supporting the World Health Organization, both politically and financially. And this will continue to be an absolutely critical area, particularly as health security issues mount, but even more, as we see now, as humanitarian issues mount. And as you followed the Ukraine war, as you followed the conflict in Gaza, as you've seen how healthcare personnel and healthcare organizations and institutions are subject to the war situation, we will see that many of these issues will also come to the fore much more in our global health discussions. But again, I will end with the need for partnership, the need to build strong international partnerships on health, which the Global Health Strategy wants to do, and to make sure, and this of course is the Team Europe approach, that those partnerships are also there between the EU countries. There is no reason that each EU country needs a separate ODA strategy on global health, for example. We could work more closely together in those areas. So let me stop here. Let me underline again how enormous the challenges are, how they are now being discussed in so many other political fora, like the G7, like the G20, like the United Nations General Assembly, like the United Nations Security Council. And it needs a strong European voice on these global issues so that we can all stay safe and that we can reach equity and health. Thank you very much.
Thanks a lot, Professor Kickbush. Dear Ilona, thanks a lot for this contribution and for somehow opening up, in a sense, our eyes besides Europe to these complex times and to the complexity of global public health, in which this One Health approach, connecting with the health of the planet, climate, the transition, the migration issues and other security, human security aspects, somehow make the situation very complex, but also extremely urgent to be addressed. I would like to invite to this digital floor Mr. Petersen, that had the chance to participate in the discussions at the conference on the future of Europe. And I'm quite sure that some of the long list of suggestions that the citizens panel and the conference put forward might be in line with what we have discussed now. So basically, I'm giving you the floor to tell us what was your main take from the citizens panel, from the entire discussion on the conference on the future of Europe, on the desire and needs to speed up the quality of European health sector, public health. And perhaps some comments on what you've heard this morning as well.
Yes, first of all, hello, and thank you for letting me participate. I will definitely, I'm really pleased to see that this book is actually been made, and it does reflect a lot of the discussions from the citizens panel and the Conference of Europe. Mostly I've heard today a lot of times treaty change, which was probably the most discussed subject because it was in the citizens' recommendations and it came to the conference where it was discussed, and there it met like a lot of support, but also a lot of resistance, because treaty change is a long road to go down. And therefore, also you can see in the proposal that I made from the conference, they said that we should work within the current framework to ensure the health situation in Europe, but also still working on treaty change. But I think that is kind of like, because generally the citizens of Europe wants a social health union, and I know there is this citizens panel from Netherlands that actually said the contrary, that they don't want, they want the countries to decide for themselves about health, but we actually never discussed it in the conference. It was never defended by the citizens panel. So it hardly ever made it to the conference, this, because no one actually took it up. So I know it's in the report from the Netherlands citizens panel, but no one defended it. What really filled the conference and the citizens panels was the solidarity of the citizens that really wants a better Europe. Also, we discussed a lot. We had this. We discussed a lot about brain drain. I never heard the word brain waste before, and that's actually a really interesting word that probably should have been discussed. But we didn't only discuss brain drain, we also discussed the shortage of health workers in the European Union. And in that context, there was a lot of discussion about the private sector of the health that is actually supported by a lot of education of workers that is mainly paid by the public funding and going to the private. And that is actually a big issue too, which came forward in the conference, that the private is profiting from the education of the public funding. And that also ended up in being discussed with treaty change, because before the European Union can actually do something at European level, something needs to happen with the treaties, because the framework that are there now, it's true, there are possibilities to work within the framework, but they're small. It's simply not possible to change what the citizens would like to see within a social health union. So that is part of the problem. Besides that, we discussed a lot about the private sector in healthcare, also within medicine, because that is also an issue about accessibility for medicine, that the private sector is often having the, I don't know how to say it, control over the medicine, because money rules the world, to say it short. So besides that, we discussed a lot about the, there was a lot about a wish for budget to be something that there was a talk about, maybe it should be some part of the national income that was actually reserved for healthcare. But you can't do that again on a European level without treaty change. But so it was just more or less that it would be a recommendation for member states to invest in effective healthcare. So the wishes of the citizens are there, but they're really not able to be carried out before something happens with the treaty change. And I could go on because there was a lot of more discussion, but I think I will hold it with this, because this is kind of like the things we talked about today.
Thanks a lot. Thanks a lot, Mr. Peterson. Let me invite on the stage also the other speaker, Mr. Andriukaitis and Professor Schrauen and Professor Kickbush, because I would like to maybe for Andriukaitis, to responding to Mr. Peterson, a word on the little margins that we have and how to best use them, because you wrote specifically on this. You have mentioned something, the margins that we have to act now before treaty changes, what we can do as perhaps the Commission kicks off kicks off the work somehow next summer, after the European elections. What are the first things that you would like to see enacted? And then maybe for all of you, I have two questions from Marika. She is maybe a provocative question, but I still would like to flag it because it's somehow politically very close to my heart. So she goes very simple in this direction. If we are not increasing health spending after a pandemic, what do we need to actually have the European Union covering health more diligently? And I think this is reflecting on a comment that was done before on the fiscal rules and the fact that we are going back after the next generation EU and the spending to a regime where maybe we are not back to austerity, but the feeling of investing in health and investing in care, a risk to be put once again out of the main priorities. The other question by Sasha is instead very interesting, particularly in this context that will bring us towards the election. The reflection is, what can we tell to the European citizens that can actually quantify or make clearly visible, can create appetite for a European health union, something very concrete. Can we say something, that's the suggestion, about a short waiting line for medical testing? Something like that every European citizen has a right to maximum waiting line of 1 month to get a test. Can the European Union set minimum standards in a way in which citizens directly feel the impact and understand it from better European integration? So first to Andriukaitis, and then a comment to Petersen, Kickbush, and Schrauen. Short, because we have time.
Thank you so much for this very excellent question. Of course, as you just mentioned, keeping in mind legal limits which are enshrined in Lisbon Treaty, and as you know, all institutions are under strict conditions of their legal services, because they immediately can write what is possible, what not, because institutions are legally responsible for not to overcome their capacity set limits and not to create challenges, because after every decision, Court of Justice can say sorry, but you overcome your legal your limits. It means that we should understand now very well. At this moment, we can also achieve much more if main actors are in this area member states. If member states can express their willingness to solve those problems, they can do much more, keeping in mind their obligations to cooperate, to coordinate, and to act in proper manner, because Lisbon Treaty also is legally binding to encourage member states to solve problems on the ground. But now fragmentation lies at member states level, big one, very big one. And member states also, as you know, power of health ministers in every cabinet is not so strong. Much more powerful is Minister of Finance and Ministers of Agriculture and Minister of Economy. And if you see into intergovernmental composition, you can see why health questions are out of game at member states level. And of course, when you are looking into intergovernmental area where member states are cooperating or using intergovernmental method, you can find this simple issue. Because of shared competences, ministers of agriculture gathering in Brussels, sitting around in discussing common issues, coordinating their policies every month, 12 months per year. Ministers of health, sometimes one time per year, sometimes 2 times per year, that's all. Of course, EPSCO Council is absolutely also, it's not in the same power compared to Council of Ministers of Finance or Ministers of Economy. And of course, but it depends on member states' activities. It depends on national parliaments. It depends on citizens. Why they are not pressing very much issues, putting health first, at national parliaments, then pressing governments to do more in coordination. Otherwise, you have no chance to solve brain drain or brain waste on shortages. Member states can organize debates and sign agreements between countries, between more richest countries and more poorest countries within the EU, to describe all issues. But political will is not there. And of course, we are proposing now in our scenario B what can be done using today's existing instruments. Yes, we can do. For example, the proposal is to establish a vice chairman of European Commission responsible on One Health. And of course, establishing, some expert group on universal health coverage. Or, for example, to pushing forward ideas that Commission should do more keeping in mind impact assessment when they are doing decisions, how those decisions can affect people's health. Doesn't matter, agriculture or industry or growth and so on, doesn't matter. But it depends on European Parliament also. In new working program, in new period of elections, European Parliament has also questions to raise the same. Or speaking about the European Parliament, it would be good to have vice president of the European Parliament who will be responsible also on One Health issues. It means that you can see that some institutional changes which should be done in the frame of today's Lisbon Treaty can show directions in which directions we are ready to go, and then of course it will be repercussion to national governments. It means that we have today possibilities to use all our instruments, which of course they are soft instruments. Of course they are not the same like like in area of shared competences, but we can use only one area now is in shared competence is cross-border healthcare threats. And regulation, which was done today, because it replaced decision on cross-border health threats, regulations can open also as Netta show possibilities to use some, changes in relation between the European Commission and member states, especially also keeping in mind European semester. Because European semester is quite powerful tool also. And state of health in the EU cycle can help us also raise questions about healthcare shortages, about rare diseases, about access, about unmet needs, about financial hardship, about waiting lists. All those issues are in our hands. Of course, it should be as recommendations, as consultations, but it can play game. No doubt. But of course, speaking about reality, if you can keep in mind for the possibilities to activate, European semester, but also using financial tools, it can also help to solve those problems. But I am in favor to go into both directions. using secondary legislation options, using tools which we have now, and you are encouraging new political parties and in front of new European parliaments to keep high it on the agenda, because, and of course, also going into debates about necessity to improve Lisbon Treaty, because now it's EU is in crossroads. You know, because EU now is challenging issues, enlargement, okay, and what they can do with enlargement. Okay, we need to think that window for opportunity in treaty changes also exists, and we can use such opportunity also going in such direction.
Let's create that opportunity then, and let's work for it to happen. Thanks a lot, Mr. Andriukaitis. I look at Petersen, Schrauen, and Kickbush for really short, maybe 1.5 minutes each on the two questions that I can perhaps repackage as how to convince member state to spend more on health, basically to consider that as an investment and not as a cost, with the implication for the EU. And the other is instead how we can convince citizens to, raise even more their voice for more Europe. What are the things that can make them convinced that this is the right direction? Maybe something on minimum standards, something that they can see in their weekly or monthly life, if not daily. Pedersen, maybe first.
Well, now I'm not a politician or anything, but I think that the issue's results would probably be one of the best ways to actually show it, and also making sure that it's not going private, because that is one of the main issues. That if it's going to be a private business, I think that citizens will definitely lose the initiative and to do it. And of course, I agree totally that if the member states could agree on, we can actually do anything within the current framework. But so far, we have seen that member states don't agree. There's also always one that doesn't agree, and the principle of anonymous voting is kind of like in the way of that. So that's why, if we could somehow get the politicians to open the treaties, and we have pushed a lot. I know there are many citizens pushing. I don't know if it's possible to have citizens pushing more on that issue, actually, because there is a lot of pushing right now. And it is in the report from the Conference of Europe. So unfortunately, I think it's going to be hard doing more than is already done. But that is definitely what's needed if we need a change. Thank you.
And actually, it's also true that almost every opinion poll or survey done on people's priority for youth, we've done some at FEPS as well. Health always comes as first, but unfortunately is not one of the, I would say, first or second or third priorities for European policymakers. Professor Schrauen, up to you.
Yeah, thank you very much. Yeah, what can be done to make sure that health spending, again, there will be measures of austerity. I think, the European semester should be used to make sure that member states do spend sufficiently on healthcare for their citizens. And there's one maybe a little bit of a risk, and that is connected to the second question, and that is, if member states do, then very often it is presented as member states' policy, and citizens do not know that there is the EU behind this as well. And so the politicians of member states very often say that this is national. It's, if it goes well, it is national policy. If it doesn't go well, it's EU policy. Yeah, that is what we see very often. And I think also the point about privatization is very important, and it is part of, let's say, the more neoliberal turn the economy and the EU took at the beginning of this century, and hopefully that can be reversed a bit, and healthcare it will be seen as a public good again. Thank you.
Thanks a lot, Professor Kickbush.
Well, I think there's a big danger if we look at the European Health Union, and this also applies to some extent to the global dimension, only as being related to health services. Obviously, it is incredibly important that there is sufficient financing of health services, of health systems, but a health union should also be about health. It should be about preventing health. It should be about health promotion. And member states such as Finland have taken that forward with health in all policies and with trying to gain an understanding of the well-being economy. And Europe should be a well-being economy with the goal to have excellent living conditions for its citizens, which includes health, which is why citizens are saying, we want health. They're not only saying we want more healthcare, they say we want more health. And therefore, a whole range of the other issues that have been raised here are absolutely critical for a European Health Union. That is obviously the European Pillar on Social Rights. It's been mentioned, but this is, contributes to the reduction of inequalities. And what is the key determinant of health? The key determinant of health is inequality. So if the European Union does not work together on reducing inequality between and in European countries, then we will not move forward on a European Health Union. We have issues, special policies, like, for example, the child guarantee. The child guarantee needs to have an absolutely critical dimension on improving children's health. And then, of course, you are straight away in other policy arenas, like food labeling, like marketing food to children, like the digital access of children and how marketing is done there. We also have, if you want more health, then we've heard you need to take on issues around the environment. And again, just take the issue of pesticides. If the European Union were, first of all, more consistent in relation to pesticides within the European Union, but would be very clear about the export of pesticides to other parts of the world, we would have a very interesting combination of European and of global policies. So I would just like to say it's important, yes, to invest in good health systems in the European Union, to invest in equal access to those systems, but not to think that a European Health Union means only that. And if the European Union is not ready to move, for example, into stronger regulation of the commercial determinants of health, then it will not ensure the health of its citizens and it will have failed. Thank you.
Very clear, bold, and interesting statement, dear Ilona. Thanks a lot to all of you for the contribution, Mr. Andriukaitis, Mr. Pedersen, Mr. Schrauen, Professor Schrauen, and Professor Kickbush. Thanks a lot. We conclude actually this session not only thanking you and the authors and the participants, but also showing the statement by Sara Cerdas. So stay with us so that we can follow what the European Parliament is cooking in these topics that we have been discussing today. We can give the space now for the statement of MEP Sara Cerdas, and then we conclude the meeting of today.
Hello everyone, thank you very much for the invitation and the opportunity to give some words on this very important initiative, which is the launch of this book on the European Health Union. First and foremost, apologies for my voice. I'm a bit under the weather, but I couldn't let pass this opportunity to share with you some of the thoughts we have been working in Parliament and how proud we are that this book is being launched and actually reinforcing the role and the work that we have been developing here. So starting from the beginning, the European Health Union is something that the EIHSD has been very much focused on and advocating for almost since the beginning of the term. Whereas other groups from the right wing of this house, EPP, ECR, are focused on public spending. We in the progressives, we are focused on a multidisciplinary public health approach to determinants of health, meaning the conditions that determine the health status of an individual, conditions in which we are born, in which we live, in which we get education or not, in which we work, and so on. So in the EIHSD group, we have been exploring the multidisciplinarity that it is, the science of public health, and we have been exploring Article 168 of the Treaties of Functioning of the European Union, which states that even though provision of healthcare, meaning how healthcare is provided to each individual or each community, that's a member state's competency. Protection of public health is a shared competence between member states and the EU, and that's where we work on. So it is, for us, it's very important that we tackle all stages of diseases, but one part of it that we can have most results is on primordial prevention, meaning legislating on the non-risk factors or even protective factors for health. There's a lot that we can do in that regards. For instance, we are regulating now urban wastewater treatment. We're regulating now air quality through the Air Quality Directive. Our comrade Javi Lopez is the rapporteur on this. And if we have, for instance, in giving you a very clear example, which is pollution, which a big part of it is from air pollution, causes 10% of cancers in the EU, we need to legislate air quality in order to reduce this pollution in the air. Even though EPP is a group that flags spitting cancer as the main initiative in health, when we see on the ground that's not truly what they mean, because they don't mean to beat cancer at the source, they just mean treating cancer, which is valid, but we need to look at the whole stages of disease, and if we can prevent something, isn't that safer, isn't that cheaper than just focus on the treatment? I think for us the response to that question is very clear. We're also regulating on water quality, safer roads. We have one of the highest standards for food quality here at the EU. Information for consumers, novel tobacco products. We're very much looking forward for the new revision. We also legislate on other cancerogenous substances such as glyphosate in agriculture, nitrosamines in food, asbestos in construction buildings, and radium in common day products. The list goes on, and for us it's quite clear that it's much cheaper and safer and more smart to prevent diseases from appearing and spreading than to try to cover different fires and focus on treatments that will already be either coming too late or be too expensive. So that's where we mainly focus on, and we have been working very tirelessly into making the European Health Union a reality, and in many roles that we can advance health policies within the EU and have that approach of health in all policies approach, which is the European Union health program. And we have seen here an increase in budget, mainly due to the pandemic, which made many people realize the true importance that health has in our societies. Farm to Fork strategy, the Fit for 55 package, we cannot forget that the climate emergency is a health emergency, even though there's still many deniers of that connection. The EU Global Health Strategy, which is an initiative by the Commission, something that we are working very much on now, and I'm very honored to be the shadow rapporteur for my political group from ENVI, which is the European Health Data Space, which will be kind of like a roaming for our health data, meaning if I let's hope that doesn't happen. If I break my leg in Madeira in Portugal, and then I need to remove my cast in Brussels because I'm working there, I can go to the doctor in Brussels, and they don't need to redo the x-rays, to put me through the new radiation, just to see how it is. They can log into the health data space and check my file in their own native language, in French, for instance, and see what the Portuguese Madeira doctor has written. And this will reduce a lot of the spending in health, but also reduce a lot, and it's very much important, of exams that we do that sometimes will be deemed unnecessary. Another really good report that we are developing, two of the reports that we are developing in the Subcommittee of Health, is the report on mental health and the report on non-communicable diseases. We're also regulating substances of human origin. So a lot going on. I just forgot one, which is the biggest one, which is the pharmaceutical strategy, and that will be a groundbreaking because it will streamline all the existing legislation and stimulate the single market. We know that this pharma package is in charge of 800,000 direct jobs, and emerging biopharmaceutical companies account for over 70% of the research pipeline, and there's so much that we can grow in this regard to foster innovation and investment in health, and have higher sustainability of the pharma industry within the EU and not be so much dependent from third countries. So to increase our autonomy, to make regulations more transparent, prices more transparent, and this will in turn be translated in the most important thing, which is the patients, more affordable medicines for the people. And this is also one of the reasons we have been very vocal on addressing the current shortage of medicines across the EU, because not many patients are now able to benefit from innovative medicines or treatments, but that will change with the new pharma strategy. Another big concern with the European Union is the healthcare workforce crisis. This is a constant in almost all EU member states, and this hinders the part where member states need to ensure the right to timely, accessible and affordable healthcare services. We have that member states' healthcare needs, citizens' needs and demands have changed over time, even though there's different systems, healthcare systems in the EU. But the challenges are quite common, which are the demographic shifts, meaning we have population living longer with more comorbidities, which leads to higher needs and higher demand. The advancement in medical technology, we have new medicines, products that require new sets of skills with the whole digitalization transition. And we also can, in this transition, we can have easier and more efficient procedures that can alleviate pressure in services. And we also have a lot of healthcare challenges emerging. We just crossed the biggest pandemic of the last, of the last 100 years, and we're going through the emergency crisis, climate emergency crisis, which is a health crisis. We have a high burden now of non-communicable diseases, and it's imperative that we tackle the risk factors of these non-communicable diseases. We have very known risk factors that are still very much permissive in the EU if we take a public health approach. But the problems are very much multifactorial. So the COVID pandemic, what we learned many lessons there, but highlighted the importance of having flexible and agile health systems, and this is one of the priorities of the EU for Health program, to make health systems more resilient. And here also insurance of health professionals that they can freely move between member states while maintaining the high quality of their expertise. That must be a priority, and it's a balance between recognition of qualifications, quality assurance, and patient safety. We also need to tackle brain drain, because there's many causes for this, but this exodus is creating a totalitarian health systems in the EU, where wealthier countries have better access and better indicators on accessibility and quality of care. And for this to happen, we need to have a collaboration that is fair and equitable in the EU. In order to tackle current public health issues that we are facing through, we need to adapt to the different transitions we are going through. And the European Health Union will indeed allow for more health in the European Union and to have better public health in the European Union. And the citizens will benefit from a lot of the policies that will be game changers in public health. For instance, using the examples I just gave you before, farm to fork strategy, we're going to make sustainable and affordable what we eat and ensure they are good for our health, but also for our environment. The European Health Data Space, I already gave you one of the examples, but the accessibility of data will be easier on primary data. Obviously, safety, confidentiality is one of our biggest concerns, and we're going to guarantee that, but we cannot deny the incredible innovation boost that the European Health Data Space will bring to the EU. And let me just speak a bit about the mental health report, where we're going to create and ask for a mental health strategy in the EU. So the European Health Union will shape step by step and hopefully work towards promoting healthier lifestyles, increase health literacy, so empowering citizens to take the healthier choices for themselves, and also work on increasing accessibility to care regardless of where they live. If they live in Madeira, in Funchal, or if they live in the city center of Brussels, that shouldn't be an obstacle. So let's embrace this opportunity to shape the future of health and ensuring that no one is left behind. And again, many congratulations on launching this very important book. Thank you very much.
Thanks a lot to MEP Cerdas. It's good to see that the Parliament and the S&D group are very active on the topic, not only treatment but prevention, and with a very strong focus on inclusiveness and expanding access. Again, to conclude the talk of today, I recall you that you can find all the material online, the European Health Union book, but we have mentioned today also aspects that pertain to the issue of care. So let me also stress that at FEPS we have developed quite a lot of material on the European care strategy that looks at long-term care and child care. Also, we also try to address the issue of unpaid care, which is available both as a policy study, or you can find it on YouTube as a series of policy meetings. And also on the FEPS website, I strongly recommend you to have a look at the paper done on the project that we call Breaking the Silos, the connection between health and climate, which is one of the issues that we have mentioned today. We have tried to bring this interdisciplinary approach as much as possible, because we have to, the Commission and the European Union is active on a lot of issues, but as we have heard today as well, sometimes the interconnectedness is not super well managed, and we have to do better to create positive spillovers for public health and the world climate justice, peace, security, and somehow all contributing to an agenda for well-being. Thanks a lot to all of you. Let's remain connected to FEPS and the European Institute of Health and Sustainable Development channels. All the material is available there. Thanks a lot from FEPS and all the people involved in this nice endeavor.